I am a member of the Scientific Advisory Board of TAT, and I come on an annual basis. This is really an exciting meeting where there is a good review of many up-to-date sessions on hot and new drugs. In addition, many new compounds are being presented for the first time, including their preclinical as well as clinical data. And I think last of all, and probably most important of all, there's a good networking opportunity that is in TAT on a yearly basis. I think everybody would agree that 2015 really has been very exciting in the last year as well in terms of the immune therapy, how we can actually harness the immune system to fight cancer. I think we're used to the fact that there is a tolerance that cancers exist in the body where there is an immune system that allows it to persist and not to get rid of it. So now that there are actually strategies to actually use your own immune system in the patients to fight cancer is extremely exciting. And I think also very exciting is that the treatments that we're seeing goes beyond the standard cancers that we expect to respond to immune therapy, such as melanoma and kidney cancer. We're seeing all kinds of activities in all other tumor types, not just in other solid tumors, but even in the hematological malignancies, such as Hodgkin's disease, for example. So I think we're quite confident drugs such as anti-CTLA-4, anti-PD-1, PD-L1 antibodies will be part of our standard treatment regime in the next years to come or year to come. But I think what we are hoping to see at this conference is other molecules, such as the stimulatory molecules or even some of the other therapies, such as CAR T cells, for example, that are being further showcased in this meeting. That's really trying to do some manipulation of patients' T cells outside of their body, stimulate them and put them back into the patient in the hope that these cells will help to fight the cancer as you stimulate them ex vivo and put back into the patients. And certainly that's a therapy that's been in the workings for a long time, and I think over the last few years we've learned better to how to manipulate them ex vivo to make them even more active. I think at the beginning, I think there are certain tumor types that people have been trying this to use this in, especially tumors such as some of the immune sensitive cancers, but I think more and more we would hopefully be able to use it in other tumor types as well. I think I'm going to have to wait and see what he's going to talk about. That would be something quite novel. I mean, I think basically we've been using ability to stimulate T cells, but there are other antigen presenting cells that can actually present to the immune system, and this I suspect is going to be one that we would look forward to hearing some new ways to actually present antigens to the immune system to fight it. We've been doing quite a lot of work. We are obviously, like others, very heavily interested in the immune checkpoint inhibitors, such as the PD-1, PD-L1 blockade. One area we're actually quite uniquely interested in is trying to develop actually a questionnaire to assess patient-related quality of life on immune checkpoint inhibitors, because typically we use very generalized questionnaires such as the FACT questionnaire, EORTC questionnaire. We want to personalize it and make it a specific instrument to measure the quality of life of patients on these checkpoint inhibitors. And we're collaborating with Dr. Seller in Northwestern University in Chicago, who is an expert in this area, to develop that. So Dr. Hansen, who is a young fellow in my hospital, is actually spearheading that to hopefully get an instrument out in the next year or so. Yeah, I mean, the side effects related to immune checkpoint inhibitors are quite unique. They can cause what we call immune-related adverse event, which is essentially the body can have autoimmune toxicities because the immune system can start fighting self instead of the cancer. So you can have essentially toxicities anywhere in the body, the gut, the lungs, the eyes, the bowel, anywhere. And I think to have the way to actually capture these toxicities as as these drugs almost certainly will make it into our standard regimen, I think it's going to be relevant. And many patients will be on these treatments for a fairly prolonged period of time, so how they tolerate it, I think, is going to be important. I think it would be helpful to sort of come out from it knowing how best to sort of move forward into combining immunotherapies with targeted therapies, and how to sequence it and perhaps bring these to an earlier part of the treatment, algorithm. We know that we have to start drug development in the later phase of cancers, but as ultimately the goal is to cure cancer, we have to bring it into an earlier part of the treatment regime. So I think this would be something that, as a community, we need to spend some time thinking about how to combine it with radiation, for example, which is a curative modality. I think, and also how to select patients who are most sensitive to these immune therapies. For targeted therapies, the genomics has been informing us significantly to try and find out mutations and other aberrations. Immune therapy is a very complex system that I think be able to identify predictive markers would be extremely interesting and relevant.